A 68-year-old male presented with Haemoptysis. I'm showing you his chest radiograph. Describe the findings.
All right, let's take a look. The chest radiograph demonstrates complete opacification of the left hemithorax with significant leftward mediastinal shift, as shown by the displaced trachea and mediastinal structures. Importantly, there is a bony defect in the posterior aspect of the left fifth rib, which is characteristic of a previous thoracotomy and consistent with a left pneumonectomy. In the contralateral right lung, there are multiple small, fine, diffuse miliary nodules distributed throughout all lung zones.
Given these findings, what is your primary concern or diagnosis?
In a patient with a previous pneumonectomy for bronchogenic carcinoma, the appearance of diffuse miliary nodules in the remaining lung is highly suspicious for miliary metastases from the previously resected lung cancer.
What is your differential diagnosis for this completely opaque hemithorax, and how would you distinguish them?
The main differentials for a completely opaque hemithorax include total lung collapse, a large pleural effusion, and a prior pneumonectomy. A large pleural effusion would cause mass effect, shifting the mediastinum away from the side of opacification. Both total collapse and pneumonectomy cause volume loss with ipsilateral mediastinal shift. But pneumonectomy is distinguished by surgical clues such as thoracotomy rib defects or surgical clips, as seen in this patient.
What are the other differentials for diffuse miliary nodules on a chest radiograph?
The differential diagnosis for miliary nodules includes miliary tuberculosis, sarcoidosis, chronic extrinsic allergic alveolitis, co-workers pneumoconiosis, and fungal infections such as histoplasmosis. We must also consider miliary metastases from other primary malignancies, classically thyroid cancer, melanoma, and sarcomas.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with previous films to assess the development and rate of progression of the miliary nodules. I would communicate the finding of diffuse miliary nodules in the single remaining lung immediately to the referring clinician due to the high risk of metastatic recurrence of the previous bronchogenic carcinoma. I would recommend an urgent contrast-enhanced chest CT, including HRCT technique, to characterize the nodules and check for local recurrence in the bronchial stump or mediastinum. I would also recommend a staging FDG PET-CT to evaluate for systemic metastatic disease. Given the clinical differential of miliary tuberculosis, I would recommend urgent sputum collection for AFB stain, culture, and GeneXpert testing, alongside airborne isolation precautions until infection is ruled out. The patient must be referred urgently to thoracic oncology and discussed at the lung cancer MDT.